Total mesorectal excision (TMA). Mesorectum should not be breached, and absolute hemostasis, preservation of autonomic nervous nerve, and a dissection uh, under vision are the essential principles. Both layers of the membranous anterior denovarian denobiliar fascia should be dissected off the prostate and seminal vesicle in male to have proper clearance. In TME, for the middle and lower rectum, entire mesorectum should be removed. For upper rectal tumors, TME is done 5 to 6 cm below the lower margin of the tumor, and TME improve the quality of life relation to the impotence, retrograde ejaculation, and urinary incontinence. These complications more in APR than in TME. Anterior resections. So there is another one, Hartmann's operations. This is the excellent procedure in the elderly, not fit for the major surgery. Through and the abdominal incision, rectum excised, anorectal stoma transected, and in colostomy formed. Abdominoperineal excision of the rectum for the tumor of the lower third of rectum unsuitable for the sphincter, saving the procedure. Complete excision for the rectum enhanced by the concomitant dissection through the abdomen and the perineum. Suture closure of perineum and the creation of permanent colostomy. Endoluminal stenting. Endoluminal stenting done endoscopically obtained with the fluoroscopic guidelines used as a palliative procedure or to the relieve the obstruction. Only colonic or upper rectal tumors suitable for the stenting. Palliative colostomy in case with the intestinal obstruction or the gross infiltration of the neoplasm. Extensive operation, cystectomy, hysterectomy if the secondaries are affected, and pelvic extension, Brunswick operation, removal of all the pelvic organ together with internal iliac and the obturator group of the nodes. In the liver resection, in the case of the well localized metastasis, in the radiotherapy, in the neoadjuvant setting, radiotherapy is used to either sterilize the operative field in the cancer with the suspected lymphovascular or to downstage locally. Advanced cancer with a treated circumferential resection margin. When used to sterilize operative field, used as the short course over the 5 days with immediate surgery some 7 to 10 days later. When the radiotherapy is used to downstage cancer, combined with chemotherapy, chemoradiotherapy, and given over a period of 6 weeks with a 6-week recovery period before the surgery. Also to the palliate the unresectable cancer that causing the symptom due to pain, obstruction or bleeding. In the chemotherapy, give in the combination with the radiotherapy and to the downstage of cancer prior to the surgical resection. In the postoperative setting, to reduce the risk of disseminated disease. First line therapy is bipolar. Second line therapy is the oxaliplatin, irinotecan, and biological agents such as cetuximab.